Thank you, Jay. So thank you guys for inviting me. I will be concise for the sake of time, but I think these are really interesting cases. I think these are also cases that kind of wrap up a lot of the conversation that's already happened. So I'm glad that we get to go at the end to kind of emphasize some of the important details that have been mentioned today. I have no relevant financial disclosures. So, here is a 70-year-old male, type 2 diabetic, like many of the patients that come in all of our clinics, has a history of vitreous hemorrhage in the left eye. And you can see the level of kind of pathology he's had. He's had a vitrectomy with endolaser. He's had cataract surgery. He's had a tube shunt placed for glaucoma in that eye, and then was lost to follow-up for many years. So here he is when he comes back. This is just in 2021, late 2021. He comes in, and you can clearly see he's got diabetic macular edema, 20/80 in this eye. Now, this is his better seeing eye, and 2200 in the fellow eye from presumably diabetic retinopathy and glaucoma. And so, functionally monocular. Comes in, you can see 383 central thickness. And then, like many of our patients in the clinic, receives a series of intravitreal injections. This patient in particular receives bevacizumab 3 months in a row. And here he is after that series of 3 injections. And again, many of us have seen cases like this where the anti-VEGF and specifically bevacizumab may not improve these patients, especially if they've got chronic diabetic macular edema. So he's worse now. And at this time, again, I think like many of us, the decision was made to switch to aflibercept to see if we would get a better response. And we get a little bit of a better response. We get down to 516. And at this point, there's a lot of negotiation with the patient. The patient's not really interested in trying more of these monthly injections, doesn't feel that he's benefiting. And in fact, his vision has dropped from 20/80 to 2200. So at this time, we decided to implement subthreshold laser. This is a little earlier than I would usually implement laser. I would have liked to have maybe tried a couple more treatments. This is a patient, if they had not had glaucoma, I might have tried an intravitreal steroid. But again, we're up against some variables that are, again, in real life, we do tend to see quite a bit of. So we tried the laser, and I just to briefly, my parameters, I use the Quantel yellow laser. I use dense treatment, like was described earlier, through the center, and a 5% duty cycle. And you can see a few months later that the patient, you can see much less edema. The vision doesn't feel different for the patient, but the patient decides, or we decide he's doing pretty well. So we want to watch this at this point and see how the patient does. Stable vision. Number 2 laser was applied at this point. So this is one of the questions I asked Jay earlier. When do you retreat these patients? This patient is now 6 months after their first laser. I decided to retreat this patient because there's still a decent amount of central retinal fluid with the 371 micron thickness. We start to laser through that, and we see the vision start improving as well. So here is a few months after the second laser, and you can see a significant improvement in that central edema. But most importantly, this patient has now moved up to 20/60. Again, to recap, 20/80 when they came in, 2200 on anti-VEGF, and 20/60 upon that second laser a few months after the second laser. And here's just kind of a timeline of this patient where you can see from beginning, they get a little bit worse on the aflibercept, still had significant persistent edema on the anti-VEGF, but really improve after 2 laser treatments. And the other comment I would make on this case is that we reduced the treatment burden. I think Lite had mentioned we see far fewer injections needed after this type of laser being done, and that's really kind of the primary driver of why it's a big tool in my clinic, in my armamentarium. The other interesting thing is that, again, I had mentioned at the beginning of this case, this patient was previously vitrectomized, and we see a lot of times anti-VEGFs just don't necessarily have the same effect. And certainly, at least in my clinic, I don't see the same amount of durability in these patients. So these patients require a very heavy load of injections. And again, these are the types of things that have me integrate laser into their treatment regimen earlier on in the process. And I don't think necessarily it's a replacement of anti-VEGF, but I use it in combination with anti-VEGF. So that was case number 1. And then we'll tie it to case number 2 and hopefully have some discussion or time for discussion at the end here. This is a patient, again, a functionally monocular patient, 65-year-old female, presents with macular edema in her right eye. And I'm going to move quickly through this patient's care. You can see here the left eye. I say functionally monocular because the left eye has had a CRVO, has had DR, has had a vitrectomy and endolaser. The right eye is untouched, really just presenting with diabetic macular edema at this point. The patient comes in, 20/50 vision, left eye is hand motions. And you can see here, this is a patient because she's 20/50, because she's symptomatic, because she has a near central foveal cyst, we decide to treat her with anti-VEGF. And I can show you, injection after injection. Here's aflibercept number 2 is given here. Number 3 is given here. You can see just this persistent edema. And if you look at the scan, the raster scan there, you can see the central cyst. And after the 4th, maybe some improvement in the vision at 20/40, some improvement in the edema. And then here we are after the 4th injection. So we're 5 months into her therapy, still with a lot of edema, and still, again, on that scan, this parafoveal cystic fluid. In a monocular patient with 20/50 vision, I'm a little more aggressive with treating this. But at this point, we decide, let's try subthreshold laser. Again, this is kind of a chronic edema. We've gotten the edema down to the previous points. I don't like to use laser until we've gotten the CST down under 400. The previous case I showed you was at 500 and fortunately did pretty well. But here at 305, I think it's a good use of the laser treatment. And you can see, again, yellow laser, 5% duty cycle. We address that area. And the patient does pretty well. You can see the edema starting to improve. This is just 1 month post-laser, just to check and see how the patient's doing, make sure they're not getting any worse, make sure we don't need to give any additional anti-VEGF. So I leave the patient alone here. Here's 3 months post-injection. Again, results that we haven't seen with anti-VEGF alone in this patient. And the vision is doing well at 20/40. Here's 5 months post-subthreshold laser. You can see 20/30 vision, and this is really a remarkable kind of improvement overall in the OCT findings, as well as the vision with 20/30 vision. Most importantly, the patient is thrilled with the level of clarity that she has. Here we are, 8 months post-subthreshold, just showing you the durability of the treatment effect from this first laser, and overall patient's doing well. But here's where things take a turn. The patient has lost a follow-up, like many of our diabetics, and like many of our diabetics has multiple medical issues, is hospitalized multiple times in this time period, but eventually finds her way back to us. Vision, thankfully, is holding fairly steady, 20/40, but we can see that the edema is starting to come back. Presumably systemically, she's doing worse with these hospitalizations and multiple medical issues, but she's working on getting these things under control. So at that time, we decide to implement subthreshold laser number 2. And you can see just, again, yellow laser performed. Here's 1 month post, we're seeing some improvement. Here's 3 months post, seeing some improvement. I wanted to point out, I did not laser that superior macular fluid. This is certainly worth part of the discussion. In retrospect, I probably should have, but I didn't. But you can see here, I didn't, and that area of edema persists, whereas the temporal and infratemporal fluid does improve. That was the lasered area. And then you can see this is a few months later, the patient's coming back, more central fluid this time. So I do use an aflibercept. The vision has dropped a line or two from their best vision. So I do use an aflibercept here in March. But a couple months later, we're not really seeing much improvement, especially in that central fluid. So here I decide to do laser number 3. And this time I do address that near central, that superior foveal area. And we do see 2 months post-laser, some improvement, especially in that non-central component. And then that superior component does start to improve 4 months post-laser and 5 months post-laser. And I think I have one more scan. This is just from a few weeks ago, but the patient's doing extremely well, 20/30. So really the take home here is, and you can see kind of the journey this patient takes with the OCTs, but again, a functionally monocular patient who had suboptimal response to this monthly anti-VEGF, in this case, aflibercept, and just again to show treatment burden, right? In 4 months, this patient had 4 intravitreal injections, but in the course of 26 months had 3 subthreshold laser treatments, just again highlighting the durability of these treatments. but also, the potential use in combination with the anti-VEGF. So with that, hopefully we can have a few minutes for discussion.
Fantastic cases. Thank you so much, Veeral. I think we saved the best for the end. Very nice cases. Just a couple of thoughts, and I would love to hear from you. I did notice that very nicely you showed that you primarily do a volume OCT volume thickness map based treatment, which is something which I would love to do that. And this is what we do even on the Nebulas, where you can import the thickness maps and then make the plan according to the thickness, which is really great. And one thing which I really would like to specifically say about your cases is that there was no rebound edema what we experience with our anti-VEGF patients, that when you stop the anti-VEGF, there is always a rebound. And in your cases, there was no rebound, which is really one of the biggest boon for the laser treatment for our patients. And just one more question I have is that, have you experienced, I'm just going off track a little bit, have you experienced doing subthreshold laser for PDR eyes? I have done it, but I would love to hear from your experience first.
Yeah, I mean, are you saying in the periphery or in the macula
Yes,
in
in the
general?
periphery. Yeah.
I have not. I think I'm more like Pradeep, and I try to target some of the PRP to the ischemic areas. I don't have the Novelos or the target ability, so we're just doing it. We're eyeballing it based on wide field FAs. But no, I have not tried it, and I'm curious to see if that's of any benefit.
We did some. I did one of the studies long ago where we randomized the 2 eyes of patients with very severe NPDR or early PDR, and we did 1 eye conventional PRP and 1 eye we did subthreshold. And I was surprised to see that the patients in the subthreshold group also did really well. But I would not take too much of time, and I'll let Pradeep ask his question.
Yeah, Veeral, great cases and great presentation. For that first patient, where there was still a little bit of fluid temporally, it looked like most of that edema was temporal to the fovea. Have you ever paired, the subthreshold treatment to the general areas of thickening, as we might have done previously with grid laser, but then after some of that fluid has dried up, maybe target any leaking microaneurysms with either subthreshold or conventional laser?
Yes, and I think I do that fairly frequently for the non-central kind of focal diabetic leakage. I think standard laser works great, and I think for these patients in particular, because of the central edema, I think that's why we selected to do the 577. And I think the other thing is I think one of the things to highlight is this is just one tool with lots of tools that we have for our diabetics, and sometimes, in these cases, one of the reasons I want to highlight these cases is, you've got vitrectomized eyes, you've got glaucomatous eyes. And so I think these are cases where our standard approaches don't always work well. And Pradeep, to your point, I do tend to see more diffuse leakage in these cases, right? They tend to be more chronic and just vasculopaths in general. So it's harder to kind of get focal laser in as effectively.
Great. Any other questions? Great. If because your cases were so good, I just kept one more question for you. That have you tried subthreshold laser for any of your diabetic macular edema patients? Anybody else in the panel can also chip in. No injections, but just as a primary treatment. Veeral, any thoughts?
Yeah, there's always cases where we can find that we do that. So I do have a handful of patients like that, especially patients that I feel like follow-up is going to be an issue, right? Because I think the concern is always the issue you mentioned, which is rebound, lack of durable effect, right? I know if I give an anti-VEGF, they'll be good for maybe a month, 2 months, 3 months, but what happens after that? And so in patients where compliance is going to be an issue, I may consider that as an early or first line. But in general, especially in patients with central edema, I will tend to use anti-VEGF as a first line almost universally, and then look to laser as an adjunct. Again, not a second line, but in combination.
Great, thank you.
I have used in patients with better than 20/25 vision. I have done micropulse laser in those diabetic macular edemas.
I
Oh,
have
that-
to for patients who meet CSME criteria, or it's like a disc diameter outside, disc diameter away from the fovea. I like treating those patients with laser rather than with anti-VEGF.
That's good. Thank you. I think we are good with the questions. Lide, would you like to thank everybody?